Welcome to the Derm Vet podcast, where pet skin is always in. I'm Dr. Ashley Bourgeois, board-certified veterinary dermatologist, skin nerd, and your go-to guide for everything itchy, smelly, and inflamed. I'm here to take the itch out of your day and make derm more fun than frustrating. Grab your microscope and let's focus in. All right, you guys, he is back for round 2 of this particular one. He's already been on before. Dr. Alex Sigmund is back. We are going to talk about mostly non-allergy stuff, but again, because the skin is often around the eyes and we can have some kind of spillover between our two specialties, I got some questions that were not necessarily allergy related that I wanted to pick your brain out. Don't pick your brain out about, we're neither one of us are neuro. But he is back. You can catch him on Instagram under the Vet Eye Guy. Alex, thanks again for giving us your time to talk about eyeballs today.
Any excuse to talk about eyes.
I know, we're
day,
so nerdy. We really are.
are.
What's funny is this episode will release around like the day before Halloween. So I feel like it's a good creepy topic for us to do, right?
Yeah.
So let's start out kind of really big, and it leaks over a little bit from what we talked about last week. Our first question, what is the most common reason for periocular alopecia? I know this is and I can jump into, it's a huge topic, but what's the most common reason you see it as an ophthalmologist?
I think it honestly is a form of atopic dermatitis most of the time that I'm seeing them. But I think probably the same differentials that are going to be on your list are on mine, where I'm thinking about Demodex or dermatophytosis, sometimes even them just rubbing at their face. And then we have to look at, okay, so that's just a symptom of the actual problem, which is probably atopic dermatitis, or are they rubbing because of their eyes are irritated, giving themselves excoriations from the eye being irritated from KCS or allergies, glaucoma, things like that.
Yeah, we definitely see a lot of periocular alopecia from atopic dermatitis. I mean, there are studies looking at distribution, and that can definitely be a big one. Big key things is usually it's bilateral. So it'll kind of come in, right? Because it's like a really systemic itchy disease and cutaneous and spread out. So they're just really kind of rubbing at both of those areas. They're often like alopecia, lichenified if they're really chronic. They can rub their face on the ground from otitis. And so that can just kind of secondarily, if they're really rubbing their face into the ground, cause a lot of issues around there as well. And yes, everything you mentioned, Demodex is a huge differential. So we'll do trichograms, because I don't like to scrape around the eye. So if they're not sedated, then I do a trichogram and look for Demodex. Dermatophyte, certainly anything that can cause a folliculitis. But man, we see just a lot of malassezia and pyoderma around that area from them scratching. And I will do, depending on how much of that area is affected, I'll do a direct impression smear, but I tape around the eyes. That's one of the areas I will do tape cytology more. If they're a wiggle worm, I always tell the owner, my goal here is not to send you to ophtho by me jabbing a slide into the eyeball. That's like, you already have one specialist. I don't want you to have another one. So yes, we absolutely see a lot of atopic dermatitis, potentially food allergy caused periocular alopecia.
Mm-hmm. I think of atopic dermatitis dogs, about 60% of them can have ocular signs, according to one of our studies. And then the most common sign of that in general is just redness. So I think over 90% of those dogs will be red as their main sign, but we'll definitely see the alopecia too.
Yeah, definitely. This one we talked a little bit about last week, but I think it's a good one from a general standpoint. And we went into more like steroids, antihistamines. This is a question about topical antibiotic use. So what topical antibiotic can you safely use around the eye? Clearly, that's a big question. I think a lot of this is probably also going to judicious use or thought of length, because we're seeing a lot of, in the human side, we're seeing a lot of shorter duration of antibiotics, like trying to treat things faster, stronger, which topical, the nice thing is it's directly where the issue is. So you get a better concentration, kind of like what we deal with ears. So what's your take on that?
Yeah, I mean, most of the time I don't need to reach for a cream of an ointment around the eye. The times that I have specifically are immune-mediated blepharitis cases that can benefit. I do use Neopolydex most of the time for them because I am worried about secondary infection of the normal flora because they do have open wounds and ulcerations. So the meds that I will use around the eyes are the ones that are good on the eye. So I'll use erythromycin. You have some ophthalmologists will use a topical antibiotic on like incisions. So if they had an entropion surgery. So pretty much the short answer is if it's safe to go on the eye, it's safe to use around the eye. I think that the second part of that is why are we using it? What's the goal of using these? And then of course, determining how long they need to be on it.
And I think probably a lot of that question comes back to maybe wanting to give freedom to the owner, kind of like we talked about last week with chronic steroid use, right? And you have to be cautious of just sending home like a Neopolydex. And we send home Neopolydex sometimes for some of the stuff that we do. We deal with some of these like immune-mediated periocular disease cases, and maybe they do have a little infection I don't want to put them on a systemic for. So we'll utilize them in some of those cases. But I think it's always tricky when you talk about freedom with these topicals, right? Which is why we often try to use more, and can't get this necessarily in the eye, but when we're dealing with the skin, we're trying to get more of, okay, freedom with a chlorhexidine mousse, not freedom with a topical antibiotic per se, because of all the things that we're nervous about with resistance long term. So I think when we get asked about like chronic steroids, chronic antibiotics, kind of like what can we give owners to use when needed, but sometimes it's just maybe not the best option. Like maybe we really do need to see those cases in those situations, or we have to question the underlying cause to your point. Maybe something else has popped up. Maybe we have another issue.
Yeah, and I think some other options besides our or those particular antibiotics and steroids, you can use SSD around the eye. You can put that even in the eye.
Can you?
Yeah, so you can use SSD.
Because we do use a decent amount of SSD, like, because we get like ulcers and it can be helpful with ulcers with the silver. I didn't know that could go in the eye.
It can. We'll use it pretty routinely in equine ophthalmology where it's just directly put on the eye.
Like the tube that you get, like the human product.
Yep.
You heard it here. I learned something today.
And then if you did need some type of cleanser, so instead of chlorhexidine, then you want to use a betadine solution that's been diluted 1:50. And then you can use that as a cleanser around the eye if you needed that.
That was one of my favorite things that one of our local dermatologists taught me like 5 years ago. We were overlapping when I used to do a satellite in a multi-specialty hospital. And I was asking her kind of about a case of mine that just had a little bit of like periocular infection, but I just didn't feel like it was bad enough to treat with a true antibiotic. She's like, you dilute betadine. I'm like, what? I mean, it's so cheap and easy, and they can just get it at a local Target, pharmacy, any of those things. And that's what I've actually, hopefully this is not the incorrect thing to do. That's actually what I've given more freedom of owners to do around the eye.
Sure.
Is like just betadine as needed if they get a little infection from their allergic disease.
Yeah, I think that makes total sense. I think the key is to make sure you're getting betadine solution and not scrub.
Okay.
Because scrub you cannot use around the eye.
Okay, fair. I will definitely make sure that's what I'm doing. I think so, but let's make sure. I love this. Is not a question. This is a statement for guidance, but it cracks me up when people write stuff like this. Okay. Ready? Blepharitis. Ugh.
Oh,
that's it.
Everyone.
That's all you get.
That's how everyone feels.
Go. See, I don't manage really blepharitis because if they're like that bad, then I'm probably sending them to you. So I guess, again, big picture view, knowing that's a huge topic on its own, just basic guidance in blepharitis.
Yes, so blepharitis is the bane of ophthalmology as well. And if it is really bad, we send it to dermatology. So I think that's where having the collaborative approach between specialties will be helpful.
Like, I think we feel better being braver if you guys give us permission, right? I think that's where sometimes this relationship is we may be doing the crazy steroids or something like that or working things up more, but we just want to make sure there's nothing truly wrong with the eyeball. Yeah,
absolutely. And that makes total sense. I mean, I think I feel similarly.
Yeah.
If you tell me it's okay for me to try something, I'll do it. But so with blepharitis, you have to kind of try and localize as best you can the cause. So blepharitis is of the skin. So we do need to make sure, are we dealing with blepharitis of skin, or are we dealing with meibomianitis, which is of the eyelid glands, because that is a different condition. And we can have, I'm sure, just like you can with anywhere else on the skin. So we can have infectious causes, autoimmune causes, parasitic causes. Maybe they're self-traumatizing, something that the self-trauma has now made it worse into your full-blown blepharitis. And so it really, to help kind of pare this down, we can biopsy. We can look at is this an atopic dermatitis dog? Is that probably what we're dealing with? If there's no history of allergies, then we do start to have to, start discussing, are we culturing the skin? Are we culturing sebum from the meibomian gland? Are we doing, because I love diagnostics. So I'm like, am I going to do a skin scrape or something and see if I see anything? I do like to do that stuff and look under a microscope.
Yeah.
And so, trying to get some more information about it. But I'll be honest, a lot of owners don't jump at those options. And so we end up managing these medically, which is usually with anti-inflammatories and oral doxycycline is most of the time kind of one of our options for blepharitis cases, because you can have kind of an allergic response to your own staph that can be a cause of your blepharitis. And so the doxy is supposedly trying to clear some of that and provide some anti-inflammatory effects. So there's a lot of different, parasitic, like I mentioned, signs of systemic disease. So if you're in an area of leishmaniasis, you can have some things like that.
Oh.
But fortunately, we don't have that in the Southeast.
There are listeners from other portions
on
of the podcast, though, because when I have done lectures in other countries, sometimes they are where they truly have leishmania. So for those of you in areas of leishmania, can do whatever it wants, I think is what we know about. That's all I really know is like it could be a differential if you live in a place or have a pet who has transported from a place that has that.
Yeah. So I think I hope I answered that question.
Well, I feel like anything really sounds like that could cause like dermatitis, right? Could basically like kind of in turn be blepharitis. It's just a really big term, but when you see it and it's severe, it can be really scary, especially for the owner, right? It can look really scary if it's bad.
Yep, exactly. And so a lot of that is if they look really bad, I'm going to maybe suggest, or I will suggest being more aggressive with the diagnostics versus if it's, I'll get some blepharitis cases that it looks like it's very focal. It's on one eyelid and you're like, this seems like a bug bite. And so we actually just wait and see if it's getting worse or is it going to get better?
Yeah. Next question. And we, again, talked about this a little bit, but from your perspective, when should general practitioners or maybe even us as dermatologists be watching, what we should be watching for in the eyes? Say we're doing a routine skin exam or they're doing a general wellness that might, like what to use, like, ooh, this needs to get to ophtho pretty quickly, right? Because a lot of things like, we can manage or give some grace, but what are the couple of things where it's like, you should get them to ophtho if that's an option for you?
Yeah, that's a great question. I feel like if they've done their ophthalmic exam and they haven't found anything scary, then you have some time. So you can take a breath. Because if we're not dealing with a melting ulcer as the cause of the discharge, then we can take a step back. If they don't have glaucoma, we can take a step back. And it may look really scary, but it wouldn't necessarily be an emergency where they have to go into emergency at 2 a.m. or something like that. But I do think that if you have that atopic dog that's now having these ocular signs, I think there's just so many factors that are involved that it may be worth just getting an opinion. On your clinical exam, most of the time, if you're seeing those blepharitis cases, just because there's so much we don't know about blepharitis, because there's really not that much literature about it. I think in our textbook, we have like a paragraph or two dedicated to blepharitis when it should be a whole talk. But, I think if blepharitis cases, it makes sense to see derm or ophtho, and we'll probably trade back and forth depending on what we're seeing and how localized things seem to be. And that's honestly probably my main one versus, dry eye, of course. If you don't want to manage dry eye cases, then of course we'll see that.
So like melting ulcer would probably be like a huge one, right? And like really bad glaucoma.
Yeah. And so these are I think from the question, thought it was, if you ruled out all the other stuff, and now we're trying to decide if between derm and ophtho, then it may not matter as much. They just need to be prepared that they see both. They may see both. And I think that's just part of the communication aspect. But yes, if you do your ophthalmic exam and you see glaucoma and you see a melting ulcer, definitely a reason to come see me.
Yeah, and I think you can take the question either way, right? Because it really, I think, comes down to when do you refer what. I talk a lot about this with my friend who's a behaviorist. Like, we talk a lot about, when is it one of us? I've had Dr. Radasta on earlier this year. Obviously, Dr. Pockel's been on the podcast, but we talk about like sometimes it's not that clear cut, and we might need both of us involved to some degree, or you need the other one to give the grace to say, okay, they can go more aggressively because I'm not so worried about my aspect of this disease.
Totally.
And then the last question, kind of a funny one. I'm interested to see what you say. I can think of a couple. Are there particular breeds where you see a strong overlap between skin and eye conditions?
Oh, that is a good question. I guess the short answer is yes. So I feel like if I see a pitty, maybe like any gray pitty, any gray animal, honestly, silver
If there's a loot
coloration.
color, something genetically could happen.
Yes,
Yeah.
absolutely. I do feel like white dogs have a hard time down here. And this is a little bit of a tangent, but I was an avian biology major in undergrad, and we talked about albino animals, specifically birds. And so they were looking at the incidence of parasites on albino animals, and that they were just like riddled with them. And they thought it was because that melanin is actually an antioxidant for your body. And so that's a foundational aspect of your immune system, kind of your innate immune system, that it isn't able to respond as it should to these insults. And so I do wonder about that effect too with our color dilute animals, and how it affects their skin barrier, which means also their conjunctival barrier and corneal barriers, and how that manifests. So I just think that that's interesting. But I would say any color dilute animal, pitties, West Island White Terriers, bulldogs for sure.
Can't you say like any brachycephalic? Because how do you not say Frenchies? It's just like they just like rub and get the facial floor dermatitis, and then they scratch, and then they get the corneal ulcers.
Yeah, I feel like I've seen less of like the Lhasas and Shih Tzus having the skin issues, but the Frenchies, the short-haired brachycephalic pugs, I've seen occasionally, but definitely young Labradors or young dogs in general can have some allergic conjunctivitis that they can grow out of. So they get something called follicular conjunctivitis. That can be at any age, but we don't know very much about it. But in my mind, I think that they have so much lymphoid tissue being exposed to all these different antigens that it gets a little overstimulated, and they get these really knobbly cobblestone appearance to their conjunctiva from these lymphoid follicles. And that we have to manage short term until they can grow out of it, which is usually like a year and a half or older. So younger dogs can have some issues with that. But breed-wise, yeah, I would say any brachycephalic, color dilute dog, any of those kind of designer breeds, I feel like we tend to see those a little bit more frequently.
There's a chance. Well, as always, Alex, thank you so much for your time and your expertise. I appreciate you teaching us all the last 2 weeks within the Derm Vet podcast. Hopefully you have some fun Halloween plans coming up. With it being on a Friday, I feel like it's going to be a crazy one here.
Yeah, go get my costume ready.
Oh, yeah. Well, listen, I have kids who want to be K-pop demon hunters, so we're as the rest of the world probably is. So
how'd you know my costume?
I'm being convinced that I am probably going to be Mira and my daughter's going to be Rumi. So, that's okay. I think we're gonna follow the masses and not try to be creative. I think this year, whatever they want. But no, I really appreciate your time, and thanks again for being on the podcast.
Of course. Thank you so much.